webinar entitled COVID-19 and the cardiovascular system from basic mechanisms to clinical perspectives. This is Yeşim Tunçok. I'm here as the president of Turkish Pharmacological Society. This webinar is organized by the Turkish Pharmacological Society and European Council for Cardiovascular Research. As of now, I've learned that the number of participants registered on the webinar is over 500. I'm very happy with the intense interest in this international scientific event. At the beginning of the new year, we are very happy to be with you in this virtual environment, although we are looking forward to being with you personally as soon as fighting off the COVID-19 pandemic. In recent days, COVID-19 threatening all over the world, the topic mechanisms of COVID-19 harms to cardiovascular system or the webinar is very important for exploring the mechanism under the cardiovascular harm to developing new treatment options for preventing and treating COVID-19 patients. It's also important to perform such a scientific webinar in collaboration with the European Council for Cardiovascular Research. On behalf of the Turkish Pharmacological Society, I would like to thank the President, Professor Marisol Fernandez-Alfonso, and the other colleagues from the European Council for Cardiovascular Research, and our distinguished speakers, Rhian Touyz and Thomas Luscher from England, Rosa Maria Bruno from Artery Society France, Matthias Barton from Zurich, and Gökçe Topal from Istanbul University for accepting our invitation. We are very proud to have them here. Additionally, I would like to thank Gökçe Topal, who is also an executive committee member of the Turkish Pharmacological Society, for her efforts on the excellent scientific organization. Other thanks go to Ahmet Altun, who is also an executive committee member of the Turkish Pharmacological Society, for his outstanding effort in establishing technical support of the webinar. For those of you just joining from Turkey and Europe, welcome again. I hope we will have a nice and interactive discussion during the webinar. Now, it's my pleasure to invite Professor Marisol Fernandez-Alfonso, who is the president of the European Council for Cardiovascular Research, to give opening remarks. Professor Alfonso, this is your turn, please.
Thank you, Yeşim, Professor Tunçok. Good morning, everybody. Thank you for joining and for the interest in the webinar. The number of participants is really amazing. So I am Marisol Fernandez-Alfonso, as you know, current president of the European Council for Cardiovascular Research. And I'm also a pharmacologist, a professor of pharmacology at Complutense University here in Madrid. So I think that the topic about COVID-19 and the new treatments and cardiovascular approaches is really very interesting. As you know, the pandemic, it has had brought a lot of problems and inconvenience, but something that I think we should take advantage of is the possibility of organizing these webinars and these meetings online, which I think, okay, we might take advantage of this, might be a positive thing in all this situation. So the European Council for Cardiovascular Research goes back more than 30 years. We organize many educational and scientific activities. This is one of these. And I want to thank especially the Turkish Society of Pharmacology, because it was really their initiative to organize this webinar. So we thought that it was really a very good idea. And here we are. We have been working the last months organizing it. And yeah, we have really interesting talks, really distinguished speakers, and I hope you are going to have fun and enjoy the webinar. I also have to thank all the Turkish pharmacologists, the people involved in the organization and also in the technical organization for this. And with this, I give the floor, I think, to the first moderator, which is Günay Yetik, who's going to start the moderation of the first session. So thank you very much all and enjoy.
Thank you, Maria. I would like to welcome to all speakers and our guests. I'm very glad to introduce you our distinguished speaker, Professor Rhian Touyz, before her plenary lecture in session 1. Dr. Touyz received her Bachelor of Science and Master of Science in Medicine and PhD in South Africa. And after her postdoctoral fellowship in Canada, she worked as Canada Research Chair in Hypertension until 2011. Dr. Touyz is now Director of the Institute of Cardiovascular and Medical Science and British Heart Foundation Chair and Professor of Cardiovascular Medicine in University of Glasgow. She is a clinician scientist focusing on molecular and vascular mechanism of hypertension. She has received numerous prestigious awards, a committee member of guidelines of the European Society of Cardiology as well. There are lots of things to tell about her, but I'm trying to make it short. She was chair of High Blood Pressure Research Council, American Heart Association, and president of Canadian Hypertension Society and International Society of Hypertension and European Council for Cardiovascular Research. She has trained over than 65 PhD students and fellows and has published over than 550 papers, and age index is 101 for the Web of Science. Now I would like to invite Dr. Touyz for her plenary lecture titled as Cardiovascular Disease as a risk factor and complication of COVID-19. Here is the stage for you.
Thank you very much. I just want to make sure that you can see my slides and you can hear me. Is that okay? You can, is it okay? Ready to go? So I would like to take this opportunity of thanking the Turkish Society of Pharmacology and the ECCR for inviting me today to share with you some of the work that we've been doing related to this very interesting topic, and also to highlight the importance of cardiovascular disease relative to COVID-19. And indeed, I'm going to talk about cardiovascular disease as both a risk factor and a consequence of COVID-19, or called long COVID-19. So of course, we are all very familiar with the epidemiology and the timelines related to the devastations that have been caused by the coronavirus 2, or the SARS coronavirus 2. And if one thinks back, it's almost to the day, a year ago, that we have seen the expansion of COVID-19 over the course of 1 year, starting originally in Wuhan. And we know today that this pandemic has affected more than 2 million individuals in terms of untimely death. We also know, at least at this point, that it seems that the primary host of the SARS coronavirus 2 is the bat, but there may be other intermediates that are responsible for the hosting this virus before it actually gets into the human population. But what we also know is, in addition to the other coronaviruses, SARS coronavirus 2 is incredibly infectious, and it is this that has resulted in this devastating pandemic that we're all facing today, wherever we are in the world. Oh dear, let me see. I think it's very timely also that, in addition to understanding the epidemiology of coronavirus 2 and COVID-19, I found this publication, which was a summary in terms of an overview of what we understand with respect to the virus and the clinical implications. So very, very briefly, we know that SARS coronavirus 2 is responsible for COVID-19. We know that ACE2 is the receptor through which the SARS coronavirus 2 mediates its effects through binding to the ACE2 acting as a receptor, and the virus and the receptor internalize and thereby induce viral replication within host cells that results in massive infectivity in the host. We know that the primary site or the tropism really relates to the respiratory system, and we should not forget that COVID-19 is a very severe respiratory disorder associated with various phases in the viral disease, and particularly the severe form being associated with hyperinflammation. Associated with this massive respiratory response is a very potent immune response, and a cytokine storm has been associated particularly with severe disease. So although we know that the virus induces respiratory infections, it's now becoming very clear that in addition to the devastations caused at the level of the lungs that we can see here very clearly in a post-mortem section, massive thrombosis, massive inflammation as indicated by the microscopic examination, bleeding, and very profound pathological changes in the lungs. We know that there are associated comorbidities independent of the respiratory disease. And if we look today at the clinical characteristics of patients who've got COVID, and particularly more severe forms of COVID, it's very interesting to note that there are a number of very common factors or predisposing elements, including obesity, diabetes, hypertension, and coronary artery disease, important cardiovascular risk factors and cardiovascular diseases themselves. We also know that those patients who are in hospital with COVID are more predisposed to cardiovascular events such as thromboembolic disorders and also arrhythmias. And these characteristics have been identified in Western countries as well as in Asian countries. In addition to the respiratory disorders and those predisposing risk factors that I have mentioned, there has also been the suggestion, and I know we'll hear a lot more about this in the next presentation by Professor Luscher, it has been suggested that COVID may be a disease of the vascular system. And very early on, it was noted that patients who presented with COVID also presented with what they called COVID-19 toes. And this is evidenced, as we can see here, by an inflammatory response. And this has been associated or implicated to be a peripheral vascular disease. And it wasn't long after these clinical observations were found that indeed it was published by a number of individuals that in the vasculature there was evidence of an endotheliitis, as we can see here. Very importantly, in microvessels, there was not only presence of COVID or SARS coronavirus 2 infection, but this was associated with an inflammatory response. And experimental studies have gone on to show indeed that the SARS coronavirus 2 does replicate in human blood vessels and kidney organoids that may be inhibited when ACE2 is inhibited. So this association between cardiovascular disease and COVID-19 was evident very early on when the disease was actually identified. But studies that have been done to clearly characterize this association demonstrated that the risk factor profile or the burden of COVID-19 was massively increased, significantly increased, the more cardiovascular comorbidities there were that were present. And we can see here in terms of cumulative risk and the time to severe COVID-19 disease, as the comorbidities of cardiovascular disease increased, so too was the severity of COVID-19, indicating again some association between cardiovascular disorders and COVID-19. We published, together with collaborators in Wuhan, a study that indicated that patients who had cardiac biomarkers where the levels were markedly increased were severely associated with severe disease. And this was associated with high sensitivity cardiac troponin. We can see that those patients who had high levels had much worse and severe COVID disease, indicated by poor survival. Creatine phosphokinase, specifically the cardiac isoform, also the higher the levels, the worse the outcomes. Pro-BNP, often associated with heart failure, myoglobin, and also CK itself. All the cardiac biomarkers that we investigated indicated to us that when the levels were above the limit of normal, there was an associated worsening of the disease and less survival in patients who had COVID-19. And slowly, the researchers and the literature started to tell us that in association with SARS coronavirus 2 in the lungs, there's evidence at a pathophysiological level, as we can see here, involving the microvessels, the large vessels, the heart itself, and of course the immune system, whereby the coronavirus 2 infection was having an effect beyond the lungs. And importantly, it had been considered that many of these pathophysiological processes were being implicated in causing systemic vascular injury and direct effects in terms of injury and damage at the level of the heart that were predisposing to heart failure, to myocarditis, to arrhythmias, and other cardiac diseases. So the pathophysiology related to coronavirus 2 and its effects beyond the respiratory system may be linked to the importance of ACE2 and its functions and its distribution. So we cannot consider COVID-19 and SARS coronavirus 2 without knowing something about ACE2. ACE2 being the receptor through which coronavirus 2 mediates its effects, as I mentioned. And I just want to highlight to you that the ECCR, together with Clinical Science and Portland Press, had a webinar last year where we spoke about ACE2, importantly because ACE2 last year was celebrating 20 years of its discovery. And if we look at the renin-angiotensin system at large, we know that the renin-angiotensin system was first described in 1898, but it was only 20 years ago that ACE2, angiotensin-converting enzyme 2, an important element of the renin-angiotensin system, was actually discovered and characterized. And since then, obviously, we have learned an enormous amount about ACE2 being more than just an element of the renin-angiotensin system. So classically, ACE2 has as its major physiological and pathological mechanisms effects that are mediated through catalytic function. In other words, ACE2 acts as an enzyme to produce angiotensin 1 to 9 and angiotensin 1 to 7 from the precursors angiotensin 1 and angiotensin 2, respectively. And we know in physiological conditions, we know that ACE2 through these peptides has, for all intents and purposes, cardiovascular protective effects because these peptides are anti-inflammatory, anti-contractile, antifibrotic, and also cause vasodilation. So how does ACE2, in addition to having these vasoprotective effects, have such deleterious effects in terms of COVID-19? Well, as I said, ACE2, in addition to having catalytic or enzymatic function, it also has non-catalytic or non-enzymatic function. And to date, there are a number of non-enzymatic functions that have been attributed to ACE2, including ACE2 acting as an amino acid transporter, particularly in the kidney and in intestine. It has been implicated to play a role in secretion and particularly insulin in the pancreas. And for our purposes today, ACE2, as we know, has been identified as the receptor through which SARS coronavirus 2, as well as other coronaviruses, mediate effects. So with that in mind, we cannot consider the coronavirus and COVID-19 without considering the importance of the renin-angiotensin system. And we'll hear a little later by Matthias about the implications of the renin-angiotensin system and the pharmacological agents to block the renin-angiotensin system relative to COVID-19. But I want to highlight a study that we published last year in Circulation Research, again in collaboration with our collaborators in Wuhan, where the question was asked, if you interrupt the renin-angiotensin system, could this induce more injury? Could it be more harmful in patients with COVID, or could it be beneficial? Because as you know, there's been an enormous amount of discussion and literature regarding the implications of ACE inhibitors and ARBs in the treatment of cardiovascular disease in patients who've got COVID-19. But what we found in a large cohort of hospitalized patients, and this has been now reproduced by numerous studies, is that it seemed that those patients who were taking angiotensin coenzyme inhibitors or ARBs had a better survival compared to patients who were not taking inhibitors or modulators of the renin-angiotensin system. And so these data suggested, at least in part, that ACE inhibitors and ARBs may not be injurious, but in fact may have some protective effect in terms of the survival and the severity of patients with COVID-19. So as I said, we cannot consider COVID without knowing a little bit more about ACE2. And what we know today is that the expression of ACE2 at both the gene level and at the protein level is very global. As we can see here, many cell types, many tissues, many organ systems express ACE2 at the gene level, and in terms of systems, ACE2 at the protein level is expressed again in many systems, as well as in the lungs, obviously. I want to highlight importantly that ACE2 is expressed in the heart, in the vasculature, and in the kidneys, important systems that do contribute to cardiovascular disease. We know that physiologically ACE2 expression is higher in older individuals, in males, and also Black individuals seem to have higher ACE2 expression than whites. Pathologically, ACE2 expression is increased in heart disease, diabetes, pulmonary hypertension, and as we have seen, there may be changes in ACE2 expression in severe COVID. Also, COVID-19, as I said, we know that the ACE2 is important, and this is evidenced by preclinical, obviously, and clinical studies. So while we have learned a lot about SARS coronavirus 2 binding through its spike protein 1 to the ACE2 receptor, causing viral entry and replication in the host cells, my lab asked the question, based on our enormous amount of interest and research that we have been doing for many years related to the vasculature and the renin-angiotensin system, we started to ask the question whether ACE2 may have effects on the host cell independently or dependently on the coronavirus itself. And we started to ask the question, may the virus, when it binds to ACE2, alter signaling in the vasculature that may have effects on the host cell in terms of its host response, whether this is inflammation or other. And so, working with the members of my team, we started to embark on a number of studies at the subclinical level, where we started to ask the question whether ACE2, as I said, once it was activated through the spike protein of the SARS coronavirus, may influence endothelial cell signaling and endothelial cell function. And we have done an enormous amount of characterization at the gene level, at the signaling level, the protein level, and also we have done a number of functional assays when we exposed endothelial cells from humans from different vascular beds to the spike protein of the coronavirus 2. And I want to acknowledge the tremendous work that we have done in my lab in a very short time. The work done by Drs. Montezano, Rios, Neves, Lopez, and Camargo, with funding that we've obtained through the Chief Scientist Officer, the NHS, and the British Heart Foundation, we start to characterize the system, the machinery related to the viral infection and ACE2 in human endothelial cells. And the first thing we needed to do was to, in fact, show that the machinery important for infection was indeed present in these cells. And indeed, we found expression of ACE2, we found expression of ADAM17, and importantly, the proteases that are critically involved in the priming of ACE2 and the membrane for viral infection. So to summarize this part of the studies that I've shared with you, we found that in human microvascular and other endothelial cell types, that exposure to recombinant human spike protein from SARS coronavirus 2 induces a strong pro-inflammatory response. We have looked at signaling through this inflammatory response by looking at NF-kappa B activation. I haven't shown that to you, but we've also found increased generation of microparticles, a mark of endothelial cell damage. And these responses, I want to highlight importantly, do not seem to be generalized phenomena, because not all the signaling pathways that we looked at were actually altered by the spike protein 1. We also know from the clinical studies that infection by coronavirus is associated with activation of the immune system and interferon signaling. And importantly, the different types, type 1 and type 3 interferons, delta, beta, and gamma, seem to be particularly important in the host response when exposed to the coronavirus. And we know that this is especially evident in the immune system. But the question that we started to ask, and particularly studies that were done by Francisco Rios, was whether there was an immune type response in terms of interferon activation in endothelial and vascular cells. And this was stimulated by the findings that ACE2 is an interferon-stimulated gene in human epithelial cells, but what happens in endothelial cells? And in this paper that was published in Cell, we can see very nicely that ACE2 expression is differentially regulated and particularly upregulated by different interferons. And so Francisco started to embark on assessing whether, again, the spike protein does induce an interferon response in endothelial cells, and importantly, whether interferons themselves induce an inflammatory response in endothelial cells that may contribute to the vascular injury that has been identified in patients. So putting a lot of work that's been published in the literature and now adding a little bit of more molecular mechanistic cell-based work, indeed the binding of the coronavirus 2 to its ACE2 receptor at the level of microvascular cells, and particularly at least the studies we've done in human endothelial cells, this might in fact play a critical role in the bidirectional interaction between the cardiovascular diseases that I've mentioned to you and the respiratory COVID-19 disease. We believe that the alterations at the level of the endothelial cells, particularly through the dysregulation of ACE2 and some of its signaling, which may or may not be associated with viral infection itself, may be underlying the priming of the virus in the context of inflamed vascular tissue in patients who've got comorbidities related to cardiovascular disease, and also to the sequelae of coronavirus infection. So with that, I will summarize by saying that hypertension is an important comorbidity in COVID-19. Although I haven't discussed, we know that thromboembolic disease is also very important. Cardiovascular risk factors, obesity, diabetes predisposed to COVID-19. The cardiovascular sequelae of the disease include heart disease, and importantly, heart failure is proving to be a really important consequence of COVID-19 and a critical factor in long COVID-19 disease. We believe that systemic disease may relate to the widespread ACE2 expression. ACE2 has major effects on disease susceptibility. And importantly, we have at least been able to show that the spike protein induces an endothelial cell inflammatory response that may predispose to vascular injury. And I know we're going to learn now from Tom that COVID-19 may indeed be considered as a disease of the microvascular system. I do want to highlight something very important though. And if one looks at the literature at cardiovascular disease and COVID-19 in PubMed, you will see that there are thousands of publications that have already been publicized on PubMed. It should be highlighted that there are still many opinion pieces and viewpoints and review articles that are highlighting these associations. And we still need very conclusive, unambiguous, good science to show the mechanisms and the true associations between coronavirus and COVID-19 and the cardiovascular diseases that I've just mentioned. And with that, I really thank you for your attention.
Thank you very much, Dr. Touyz. It was really, really interesting speech. And we have some questions. We have now, I'm sure that some more questions are coming later, but we have a limited time, so I will try to strict to the time as well. Zeliha Yazıcı from Turkish Pharmacology Society member, she is asking, could there be a relation between systemic vascular damage seen in patients and the drugs used in the treatment of COVID-19? Is there any relation with if the treatments are causing or related with these effects?
Yes, so as I said, we still need to do a lot more clinical studies to understand these relationships. So the drugs that we know that are used today for the treatment of COVID, for example, the dexamethasone, and we know today that there's been a landmark trial, the colchicine trial, which is an anti-inflammatory drug. So one would think that those drugs actually would protect against vascular injury. But in terms of drugs that target the renin-angiotensin system, we're going to learn a lot more about that from Matthias Barton in just a little while, I believe. But you know, knowing whether it's the drugs themselves or it's the disease or it's the associations that are responsible for the injury, we still don't know exactly. But the likelihood of, as I said, the drugs we use today, such as dexamethasone or the other anti-inflammatories causing vascular injury, is probably less likely.
Less likely. Actually, what I was thinking when you were presenting, I was thinking one question, and we are sharing the same question with Cynthia Naj. She is asking, why is there a lower mortality rate than in the black race, although they have significantly higher ACE2 expression? Actually, I was not aware about the rate. I was first would like to ask you, okay, the ACE2 expression is higher in Black people, and also you said that it is sex dependent. So what is the mortality rate in the people who has ACE2 expression is higher? And what Cynthia is saying, there is a discrepancy in Black people, ACE2 is higher, but the mortality rate is lower. How do you explain this?
Actually, the mortality rate is higher in Black patients, in patients from Asia. We know that actually they constitute one of the it's one of the factors that actually predisposes to more severe disease, actually. So it's certainly not that the disease or the mortality is less. It's actually higher in that population group. I should say that understanding the meaning of ACE2 expression is very complicated, because we know that it's not just the expression of the ACE2 at the gene level or the protein level that's important, but it's the functional consequences of ACE2 activation. The other thing I want to highlight is that there's quite a bit of discrepancy in terms of ACE2 expression in preclinical models of COVID-19 and in postmortem patients or patients who've died of COVID-19. So in other words, postmortem tissue. So in terms of the correlation, the exact correlation between ACE2 expression and disease, it's probably not easy to define. And as I said, there are now approaches actually using human soluble ACE2 as a target to treat COVID-19. So understanding exactly what the expression levels mean in the context of disease, it still remains unclear.
I think the connection. Oh, she's back.
Yes, I'm back. I'm sorry, my connection was gone, and I missed, I guess, your response.
I was just saying that we still don't know the exact meaning or the exact associations between ACE2 expression. The other thing, ACE2 expression differs in different cells, different tissues, under physiological and pathological conditions. So it's not that easy to just say if ACE2 is up or ACE2 is down, that might be implicated in disease itself.
But in other part, you said also in the aged people, it is increased, and we know that they are more susceptible to the ACE2.
Yes. So as I say, I think it's more than just ACE2 expression that is responsible for the association with severity.
Okay. And Rhian Touyz, thank you for beautiful presentation. And is it known why patients treated with ACE inhibitors have a better endpoint when compared to non-treated patients? The question is this one.
Yes, it seems that, again, as I highlighted in the paper that we published in Circulation Research, it seems that in those patients who are being treated with an ACE, was the question an ACE inhibitor?
Yes.
Yes. So those patients who are treated with an ACE inhibitor or an angiotensin receptor blocker seem to have less severe disease. Their stay in hospital is less compared to patients who do not have an ACE inhibitor or an ARB. I want to highlight the studies that have been done in patients who've got severe disease and patients who are in hospital. That is the association, because the question always comes up, and I'm sure Matthias will address this, as to how do we use ACE inhibitors maybe as prophylaxis in COVID? And this is a very big discussion in the community at the moment.
Okay, thank you very much, Dr. Touyz. There are some other two questions, but we can also, they are not specific to this area, your talk, so we can ask later as well. So it was really very nice presentation, and we are glad to have you here. Thank you very much.
Thank you very much. Thank you.
And yeah.
Okay. So the next presentation will be, so sorry, good morning or good afternoon in some places. My name is Francisco Rios. I'm one of the representatives of the early career researchers of the ECCR. So I'd like to introduce to you Professor Thomas Luscher. He's originally from Switzerland, where he accumulated many very successful appointments. And today, he is a consultant cardiologist and the director of the research, education, and development working at the Royal Barton in Hereford Hospitals in the UK. Professor Luscher has a vast selection of research interests, which includes vascular diseases, hypertension, atherosclerosis, inflammation, and the list actually goes on. He already published over 500 research papers, many reviews and book chapters, which made him one of the most cited scientists in the field, and also recipient of several important awards. So, Professor Luscher, it's an honor to have you with us. Sorry, Professor Luscher, you are mute.
Okay, now you hear me now?
Yeah. Now it's okay.
Good, all right. So it's a pleasure to talk to you about this topic on endothelium COVID-19, but I will also dwell on some of our work on the collateral damage of COVID-19. So I will quickly mention the unexpected or expected pandemic, lung disease, only lung disease, the endothelial aspect, cardiac injury, and then of course the collateral damage that we looked at with Oxford together, and the post-COVID disease. So as you know, this man really in December last year, no, it's a year ago, it's 2019 actually, Dr. Rhian warned of a coronavirus causing pneumonia, and unfortunately he was a victim of the disease he discovered as a young man, I think in his mid-30s. So today, ever since, we have now 100,000 global cases, and that's from yesterday's Johns Hopkins statistics. More than 2 million global deaths worldwide. And of course, millions of people affected, exactly 100 millions, as you can see here. And of course, the leading countries are the US, India, Brazil, Russia, and unfortunately, the United Kingdom. So is it a lung disease or just a lung disease? Of course, the lung has also vascular aspects, but here you see the typical features with sub areas of ground glass opacity and consolidation. I just talked to a colleague of mine who spent a week in the intensive care unit and was sick for 5 weeks and just recovered, and still gets dyspnoic when he just walks a bit faster. So it's really a bad disease for the lung. And we know that viral pneumonias can not only cause lung disease by directly affecting the organ, they can also affect, of course, the vasculature, cause inflammation, as we heard, endothelial dysfunction, platelet activation, and so on. And indeed, as has been shown a minute ago by Dr. Varga from Zurich, the case reports, 3 case reports in the Lancet showing that probably there are viruses in the endothelium, and they called it an endothelitis. And of course, viruses are known to cause cardiovascular disease. This is an old paper by Patrick Vallance, now Sir Patrick, who is the advisor to Boris Johnson, initially was a bit too optimistic when he asked for herd immunity rather than what we're doing now with masks and social distancing. But nevertheless, his paper is important, and he concluded that our findings provide support for the concept that acute infections are associated with a transient increase in the risk of cardiovascular events. And this is not the case with vaccination, which is again important today as we move to vaccinate the entire population. And as you know, in England, it's already 10% of the population, and in Israel, even 44%. So many countries are moving fast, others less so. Now, COVID, is it an endothelial disease? We wrote this piece together with Peter Libby, my friend from Harvard. And indeed, it is clear that the interleukins, as we just heard, play an important role, TNF, CD145, and this relates to the inflammasome that converts the pro-interleukins into the active forms. Endothelial activation is a crucial picture with also NF-kappa B stimulation, oxidative stress, and the damage associated with it. Interleukin 6 is also produced whenever the inflammasome is activated. And in the hepatocytes, we can then measure the CRP, that is just a readout of what we usually can easily access in clinical medicine. Pi1 is of course increased with the plasminogen inhibitor, and therefore the endogenous fibrinolysis is inhibited and fibrinogen is formed. We have dimers in the blood in these patients. And of course, thrombus formation involves platelet activation as well as fibrin formation that you see here. And importantly, it all starts with tissue factor, which we worked on for many years with Jan Steffel, Felix Tanner, and others. Together with factor 7A, leads to factor 10 activation, factor 9 further stimulates that. Eventually, we have thrombin, which is a central enzyme in the coagulation, as you are well aware of. At the same time, we have platelets forming, and this together then ends up with a solid clot. So, and of course, there's some additional interactions, positive feedbacks that makes this activation really very dangerous for patients prone to it. So first of all, tumor necrosis factor, which is largely released in these patients, induces tissue factor in human endothelial cells, as you can see here. And this is quite pronounced compared to the control. And of course, endothelial cells normally don't express cytokines a lot or not at all. But of course, cytokine expression does via TNF, interleukin-1 beta, CD40 ligand, LPS, or even thrombin itself in a positive feedback mechanism further leads to activation of the tissue factor pool and releases active tissue factor. So inflammation begets coagulation. That's an important factor here. And as you know, there are several case reports and also series showing that patients with COVID-19 have pulmonary embolism. Actually, in the series in the Royal Brompton that acted as a major hospital for intubated patients with COVID and those on ECMO, because it's an ECMO center. The CT scans in these patients showed that in spite of full heparinization, the vast majority had a pulmonary embolism of some sort or another. And of course, it also affects endothelial function. As soon as thrombin is formed, it moves ahead. When you incubate a blood vessel with thrombin just for a few hours, you can see that endothelium-dependent relaxation to acetylcholine is massively reduced, while that to an endothelium independent agonist such as sodium alpha is not. And the reason is that in fact thrombin does reduce the expression of eNOS and in this instance as well, and it can be blocked by Y2763C, which is an inhibitor, as you can see, of the Rho kinases. So this small G protein pathway is activated under these conditions, and we have a downregulation of eNOS expression and an upregulation of tissue factor, which is an unfortunate combination. This is, of course, developed by nature as a protective mechanism where bleeding occurs to reduce bleeding due to vasoconstriction and clot formation. But if it's systematic, like in COVID-19, this can be detrimental. The course of patients with COVID-19 can be divided into the viral response phase and the host inflammatory response phase. And of course, here we would need antivirals or maybe ACE2 proteins that bind to the virus, preventing its entry into the tissue in an early phase. But then, of course, the host does respond, and this is varies a lot between different individuals. And here, of course, cytokine inhibitors or corticosteroids, as shown in randomized trials, work very well. The corticosteroid trial in New England showed in particular that you have less people in the intensive care unit. Mortality may not be affected as much, but interleukin-6, Actemra, has been shown also to reduce inflammation under these conditions. So when we look at the entire tissues that are affected under these conditions, we can see that there is a procoagulant, proaggregatory response in terms of tissue factor expression, thromboxane, CD40 ligand, that all also activate, again, tissue factor. There's more net formation under these conditions, and in the lung, this can lead to capillary leak, thrombosis, and ARDS. In the heart, myocarditis has been described. I will dwell on it in a second. In stroke, also, the via cateterin are reduced, and therefore there is more brain edema under these conditions, endothelial slugging and endothelial deaths, vasoconstrictor responses in the acute kidney injury. There's also endothelium production. And of course, there is NADPH oxidase activation, reactive oxidant species, and as a result, together with nitric oxide, peroxynitrate formation that nitrosylates important regulatory proteins. And this is some work we did in a stroke together with Giovanni Camici. And here you can see that interleukin inhibition not only reduces stroke, but also improves the Bateson index, which is an index of motor inability or motor deficits. And so interleukin inhibition is an effective approach in stroke and may also be important in COVID-19. COVID-19 induces cardiac injury, and the European Heart Journal that I have edited for 11 years, this last year I did it. We got hundreds of papers on COVID-19, sometimes 50 a week, and most of them were more opinions rather than original research that we require. But what was quite clear is that cardiac injury was consistently observed. And what is myocardial injury? This is not the same as myocardial ischemia, where that we have in STEMI, non-STEMI, and Takotsubo, while myocardial injury is a direct injury to the myocyte in myocarditis, and of course also in COVID. And you can see that when we measure high-sensitive cardiac troponin over 3 weeks of time, those who had a bad outcome had much higher and increasing troponin levels under these conditions. Whether this is myocarditis, I will dwell on in a second. And of course, that's again the embolism And then, of course, also perimyocarditis with cardiac tamponade was described. And of course, also Takotsubo syndrome, because of dyspnea, the feeling of dying out of, being out of breath could be a stimulus that triggers Takotsubo in some patients. Now, is there pathological evidence that the troponin increase in patients with COVID-19 is really myocarditis? And Renu Virmani and her team did a nice job, and that they looked at a relatively small number, one has to say, of control patients. These are H&E stainings, and these are control patients that died of a car accident or something like it. COVID-19 patients, and this is true myocarditis not induced by SARS. And so what they found is that the total number of CD3 cells reflecting T cells particularly is increased in trauma somewhat, but not significantly. But it's actually reduced in COVID-19, while typically this is increased significantly in true classic myocarditis. So they concluded in their take-home figure that in their small series, one has to say, that only a few patients, in fact, 2 had myocarditis that had also COVID-19, and then, of course, they compared myocarditis, non-COVID myocarditis and COVID-19 patients with without myocarditis, but cell infiltration. And they showed that they had particularly macrophages in the myocardium, but no myocyte necrosis that is typical for myocarditis. So most commonly, this is sort of a leakage of troponin from the myocytes that we see when we measure this marker, but it's not really a true myocarditis when we look at the histology of it. So now the question is, these vascular problems that we saw here, how does this translate into clinical presentations? And Marco Metra from Brescia, who used to be the world champion in mortality of COVID-19 worldwide at some point in time this spring, has put this together in the Heart Journal. First of all, they showed in around 100 patients that those with no cardiac disease had a better survival than those with cardiac disease, where mortality on average was in the range of 30% in 2 weeks' time. So really a bad disease. I mean, this is almost as bad as cardiogenic shock in acute myocardial infarction. They then looked at the outcome rates in different conditions. ARDS is, of course, pulmonary complications of COVID-19. And there, of course, those with cardiac disease had a 23% mortality rate compared to 15. Venous thromboembolism, 17 versus 6. Arterial thromboembolism, much less common, 6 versus 0. Septic shock, 11 versus 0. And overall deaths, 36 compared to 15%. So more than a doubling of the death rate if you have some form of cardiac disease. So, but what's more important, I think, in the end, than the direct effects of COVID-19 on blood vessels, the microcirculation, on cardiac injury, and so forth, is actually the collateral damage of COVID-19. Now, in principle, you would expect also more myocardial infarctions because we did this work together with Willibald Meyer at the time, where we showed that interleukin-6 and many other cytokines are hugely increased at the site of coronary occlusion in STEMI patients. So in this cytokine storm, you would expect more infarctions, particularly also because of thrombi in infarction contain a lot of macrophages. And as I showed you earlier, in the heart also, there's more macrophages in patients with COVID disease. But what we actually observed in England, and this is a paper we wrote together with Colin Bajan from Oxford, was that in fact the overall acute coronary syndromes have dropped significantly even before the lockdown imposed in spring, and then recovered after a while. And this was more pronounced in non-STEMI compared to STEMI. Now, of course, there are several explanations for that. Were the patients shy of seeing the hospital? This may explain why there was a bigger decline in non-STEMI that has sometimes only intermittent pain rather than STEMI, where you can hardly imagine that somebody stays at home without feeling anything. But of course, there may be issues with that I will dwell on in a minute. There also, same was observed in Italy, where, as you know, that was badly hit in spring. And here, if overall there was a 50% decline in hospital visits in the emergency room for acute myocardial infarction. Again, this was more pronounced, 63% with non-STEMI, double as much as with STEMI, but overall less in a myocardial infarction. And so we wrote this piece with Filippo Crea, Decreased Myocardial Infarction Admissions During COVID Times. What can we learn? And what is the reason actually? And of course, first of all, fear of contagion is certainly an important one. And I also see that when I talk to patients now with my telephone clinic, and we want to ask them to come for a procedure, they're very shy of doing so. But also, lockdown means life in standstill, and without any exercise or vasoconstriction or any form of anxiety or anger, there is very little plaque rupture. There has also been a suggestion that air pollution may play a role. We went further with Chris Gale, John Dienfield, and others to look at the place and causes of acute cardiovascular mortality during the COVID-19 pandemic. And here we have looked at stroke, acute coronary syndromes, heart failure, pulmonary embolism, cardiac arrest, aortic diseases, infective endocarditis, shock, VT, VF, and deep vein thrombosis. We didn't see much of arrhythmias. That's contrary to Italy that I will show you in a second. What we saw is a change in stroke, acute coronary syndromes at large, care at home and hospital. Of course, in a hospital it goes down here as well, and at home is much more of it. Same for heart failure. So basically, and pulmonary embolism also a little bit. So basically, people die at home and don't show up in the hospital. And this is again seen with the cardiovascular deaths at home that you can see here after the lockdown, and death in the hospital shows the other picture the other way around. So this is a collateral damage really. COVID-19 kills at home. And here Enrico Baldi from Lombardia looked at this in terms of out-of-hospital cardiac arrests. And here you see that in the different areas in Pavia, Lodi, Cremona, Mantova, and altogether, there was an increase in the cumulative incidence of COVID-19 deaths out of hospital arrests per 100,000 inhabitants. And this is the difference to the previous year. And you can see there's a clear increase in events. Again, possibly because people don't go to the hospital, and then of course, out of hospital, they arrest. Now, of course, there has been some chat already, but we will dwell on it further later on. But cardiovascular disease, drug therapy, you can see here again the risk factors that were discussed. If you're elderly, you have a higher odds ratio. If you have coronary disease, congestive heart failure, arrhythmias, COPD, and if you're a smoker. So unlike some smokers suggested that if they have some smoke in their throat, it would kill the virus. It doesn't. It kills your cells, and the virus has an easier way of killing you. But ACE inhibitors and interestingly also statins were protective, again suggesting that these vascular protective drugs, indeed both of them, improve endothelial function and have some other positive effects, anti-inflammatory effects, in particular the statins. They are also protective in terms of mortality under these conditions. The last point is post-COVID disease. And if you have some friends in your family or beyond that had the disease, they will all tell you that they're terribly reduced in energy, they're fatigued, they are breathless if they go up the stairs. And of course, that may relate to involvement of the heart. And this is from ECCR from Frankfurt, looking at outcomes of cardiovascular magnetic resonance imaging in patients recently recovered from COVID-19. And they found lymphocytic function-associated antigen 1 and CD45 Rho. And of course, some indication of changes in the myocardium under these conditions, although this has been challenged by others, and it's not known what clinical implication this has. More importantly, this preprint from Stefan Neubauer from Oxford is of interest, where they looked at medium-term effects of SARS-CoV-2 infection on multiple vital organs, exercise capacity, cognition, quality of life, and mental health post-hospital discharge. And what they found is that, in fact, if you read it on MRI, tissue signal abnormalities were seen in the lungs in 60%, in the heart in a quarter, in the liver in 10%, and in about a third in the kidneys. And most importantly, the 6-minute walk test was significantly prolonged by more than 100 meters compared to controls, as was the oxygen uptake. So these patients have lots of troubles after the infection. So this is really a bad disease that doesn't just go over like a flu, as we thought initially a year ago. So with this, I would like to show again our central figures on the inflammatory pathways involved and the organs affected by it, like the lungs, the heart, the blood vessels, the brain, the kidneys, and of course the coronary arteries. I'll thank you for your attention.
Okay, thank you, Professor Luscher. We have a really nice presentation and impressive data. So we have some questions. Do you think, is there any effect of COVID-19 in the cardiac rhythm?
Yes, I mean, these out-of-hospital arrest patients in Italy that I showed might have had ventricular fibrillation, but we don't know for sure. In England, we didn't see an increased mortality due to VF and VT, so it's a bit controversial. I don't think that's the major problem with COVID-19, but rather occlusion of blood vessels on the venous and on the arterial side.
Okay, so another question is it known that always it's observed a hypercoagulability in COVID-19 patients? So these patients usually probably take anticoagulants. Do you think it's for how long?
Well, whenever somebody asks me what to do when they started to realize that they have COVID, I do recommend to take a NOAC immediately. And I would also take it as long as you're fine. One friend of mine had COVID and was in the hospital, was dismissed, discharged at home, and a couple days later had to be brought back by helicopter because of pulmonary embolism. So you can still have thromboembolism after recovery. First of all, because the thrombi hang around in the vena cava even after that, and possibly because the inflammation in the vessel wall is ongoing.
Okay, nice. So another question here is that it is observed high incidence of cardiovascular severity in COVID-19 patients, as you mentioned. What's your opinion? That they are due to virus infection or because of the inflammatory response? Because they are so different.
Yes, I think that the inflammatory response really kills you. And that is also interesting that some patients, even couples that live together, only one partner, usually the male, because maybe they have more ACE2, gets the severe form of the disease, and his wife is doing quite well. And so also in my own, among my own friends and collaborators, the females that had it had a rather mild form, and the males much more symptoms. So, but even among males, it differs hugely. And as we know, these are the risk factors I showed you. If you have any form of cardiac disease, because you already have some chronic inflammation, usually, then you get a much more severe response to the virus. It's like in heart failure, you know, a little bit of sympathetic activation is good, but too much of it kills you. And the inflammation is the very same thing. It's like in rejection in transplant patients that basically kills the organism that it wants to protect.
Mm-hmm. So there's another question here, is that the Corona trial reported that colchicine can prevent complications and hospitalizations. So I wonder, Professor Luscher, so, your opinion about the trial and possible role of colchicine in the patients.
Yes, that's a very interesting question. Colchicine actually inhibits NLRP3 and also interferes with tubulin alpha and beta assembly, and thereby exerts anti-inflammatory effects. And that's why we take it for gout when you have, a really inflamed toe. And so these two trials did use this in patients after myocardial infarction and in stable patients that had an infarction in the past, that the majority, that's the Lodo-Co trial, the other one is the Colco trial. Both show a significant effect of the combined endpoint, but I have to caution the enthusiasm because in Colcott, it was actually only the revascularizations that went down. There wasn't a significant effect on myocardial infarction and certainly no effect on death. In Lodo-Co, there was a significant effect on myocardial infarction, but no effect on death. So mortality isn't changed. So maybe colchicine is not as good an anti-inflammatory drug as we would think, compared to, when we look at Contos trial. The Contos trial had much more effect. But it's cheap, it's relatively well tolerated, and so maybe we should really look into it in more detail.
So one last question. I know it's difficult, but if you could predict, do you think that in 10 years' time, we'll see an increase in the cardiovascular incidence of cardiovascular disease in these patients that they're infected today, but that they're cured?
Yeah, that's a good question. I think what we will see, as I showed in my last slide, is certainly that many patients will no longer be as fit as before the infection, because the scars that they see in MRI, they will not disappear. I mean, we know from myocardial infarction, if you have a scar, you have a scar. And that means that the exchange surface for oxygen remains impaired. Whether the changes in the myocardium are really important, I don't know. That we have to learn more about, because also most myocarditis actually recover quite well. So that's a bit uncertain. But what we certainly know is that the collateral damage induced by myocardial infarctions treated at home with tender loving care will lead to an increase in heart failure. I would predict that we see more patients with heart failure already this year, but certainly next year.
Okay, so thank you very much. Really nice presentation. So we'll go for the next questions now, next session now. Thank you.
Thank you very much.
Thank you, Dr. Rifer. We have so many, so good presentations here, and the questions are coming and coming. But I would like to. I hope you will understand. We can not ask all questions, but if we have time at the end, we can ask these questions. Now, thank you, Dr. Luscher, and I would like to open the third session and the roundtable COVID-19. So here we will have 3 speakers in this roundtable, the titled as New Evidence and Possible Treatment Options Targeting Cardiovascular System. The first talk in this roundtable will be presented by Dr. Rosa Maria Bruno. Let me introduce her. Dr. Rosa Maria Bruno is an MD, PhD, and internal medicine and hypertension specialist. She is currently researcher at the Paris Cardiovascular Research Center in France, and her main field of research is the non-invasive evaluation of functional and structural vascular alterations in traditional and emerging cardiovascular risk factors, as well as sympathetic regulation of vascular function in hypertension. She authored more than 130 publications in peer-reviewed PubMed index journals and H-index of 26 and more than 1,800 citations. She is member of Executive Committee of the Artery Society and the European Society of Cardiology, Council of Hypertension Nucleus. I'm honored to meet her through our co-section VaskHNet, where she is among the initiators of this action and leader of Working Group 4 for data and research studies in this network. She leads the Cartesian study to investigate the effects of COVID-19 on arterial stiffness and vascular aging. And now I would like to invite Dr. Rosa Maria Bruno for her talk on vascular aging.
So, Günay, thank you so much for the kind introduction, and I'm really pleased to speak at this meeting, and after such distinguished speakers too, I must admit. And so my role in this meeting is to present the subject of COVID-19 and vascular aging. Of course, my talk has been absolutely, it will be absolutely easy because it was introduced by the brilliant presentation of Rhian Touyz and Thomas Luscher about cardiovascular risk and COVID-19. So I will just focus on what is vascular aging, how to measure vascular aging, and then I will present our project, the Cartesian study about vascular aging and COVID-19. And finally, I would really like to present you some preliminary data we obtained in our center about vascular aging during total lockdown in non-COVID patients. So what is vascular aging? The concept is very well known since many centuries, I would say. Like Thomas Sydenham said, a man is as old as his arteries. So it is really an intuitive concept that some individuals may have the same chronological age, but a totally different vascular age. So our vascular system may age at a different rate than our cells indeed. And what it is particularly dangerous for us, for our health, is the phenomenon of early vascular aging, or EVA. We can say that classical cardiovascular risk factors, but also emerging or unknown situations and conditions may make us skip our curve of vascular aging from the healthy vascular aging to the early vascular aging. And this may lead to premature cardiovascular manifestations such as myocardial infarction, stroke, and atherosclerosis, but also to cognitive dysfunction. So it is a phenomenon that we would like to stop. And of course, it has a serious impact on public health. Many many initiatives in the world are supporting the concept of promoting healthy aging, also because our population, especially in Western countries, is aging very fast, and we will reach more than 20% of the population having more than 65 years in 2050. And this could be an important part of the increase of health expenditure, which is really due to this demographic change. So this is why it's so important to know our own vascular age and to have good tools to measure it, because this is a way to achieve an healthy aging. So how to measure vascular aging? There are many ways to measure vascular aging. One which is really simple is to use a tool, like for example, this one is that one promoted by the British Heart Foundation. And so you can calculate your heart age based on your age, sex, height and weight, classical risk factor, blood pressure, ethnicity, and even postcode and other diseases. And so you can obtain indeed a number. For example, this is what I obtained. I have no risk factors, so my heart age is exactly my chronological age. And this is exactly the concept. Vascular age for this model is the age of a person with the same predicted cardiovascular risk, but with all the risk factor levels in normal ranges. This, of course, this approach has many advantages. It is very simple, so it's applicable to large population, and even for self-evaluation, like I just shown to you. And so it's very useful as an educational tool, and this has indeed implications for improving the cardiovascular risk of our patients, because the understanding of the concept of vascular age and how we can modify it, it is very important to have a better compliance to an healthy lifestyle and treatment. But this approach has also disadvantages, because we must admit that it is not enough personalized. So we have individuals, we know very well that there are individuals with the same exposure to classical risk factors, but they may develop different degrees of vascular and cardiac damage. So indeed, we can distinguish individuals with early vascular aging, individuals with normal vascular aging, but even individuals with supernormal vascular aging. So individual with for example, that they have an extremely low rate of cardiovascular event despite a large burden of classical cardiovascular risk factors. And another important thing that is that kind of algorithms take perfectly into account the burden of classical cardiovascular risk factors, but they cannot take into account the role of emerging or novel risk factor. And this is, of course, the case of COVID-19 too. So it is advisable to have measurements of direct measurements of vascular age. So in this slide, you can find a short summary or different techniques or approaches that you can use to assess vascular aging. There are molecular and cellular biomarkers, and then there are imaging and functional explorations of the arteries. So the large arteries or the small arteries, we can check for functional alterations or for structural alterations with invasive or non-invasive tests. So it's a large field of research. And just would like to show a short contribution that my group gave to the research to this field. Indeed, we were able to develop an algorithm to calculate vascular aging, and the calculation was based on the best fitting model for age prediction based on cardiovascular risk factors, treatment, and pulse velocity. Thanks to this algorithm for vascular age calculations, we were able to identify three groups in the general population. So the early vascular aging individuals who has indeed a higher incidence of cardiovascular events than the normal vascular aging group, but also the supernova group. So the supernormal vascular aging, which have indeed even an older chronological age compared to the other two groups, and a similar burden of cardiovascular events, but a reduced incidence of cardiovascular events. So let's move to the main topic of my presentation, which is the vascular aging and COVID-19, and so the Cartesian study. Cartesian stand for COVID-19 effect on arterial stiffness and vascular aging. This multi-center initiative was launched by the Artery Society, the Association for Research into Arterial Structure and Physiology. And of course, I don't have to explain you the rationale of this study. We already seen the mounting evidence about COVID-19 as an endothelial disease, and so the endothelial damage is a driving force for many complications of COVID-19. But what it is important to understand is that usually after an acute inflammation, the next step is a fibrosis. So COVID-19 is suspected to induce long-term consequences on the cardiovascular system. We already have some preliminary data on the heart with the MRI series, for example, but also echocardiography studies showing long-term consequences of COVID-19. So our hypothesis is that COVID-19 may induce a similar kind of damage, an early vascular aging, also at the artery level. And this, of course, may be due to the direct effect of viral endothelial infection, as already shown also by the brilliant presentation from Professor Touyz, but also by an indirect effect. So the marked systemic inflammation response that we may see in many COVID patients may per se induce an accelerated vascular aging. There are many studies conducted in the past, for example, about hospitalized pneumonia, which is associated with an increased cardiovascular mortality in the long term. And so there are many mechanisms connected inflammation with the structural arterial stiffness. So our study is aimed at evaluating the presence of early vascular aging in COVID-19 survivors. And we are recruiting patients with a different degree of severity of the disease. So patients hospitalized in intensive care unit or in medicine unit, but also non-hospitalized patients, and also a control group of non-COVID patients. In this prospective multi-center study, we planned 2 visits. One is 6 months and the second is 12 months after a proven COVID-19 infection. At these 2 steps, the patients undergo a comprehensive panel of vascular aging tests, starting from carotid femoral pulse velocity and the central hemodynamics assessment, but also flow-mediated dilation, so a functional test of vascular reactivity, carotid radial structure and function, and cardiac ultrasound. A long-term follow-up has been also planned for this cohort. And which is our final objective? Indeed, is to find the best way to measure the process of vascular aging in individuals with COVID. And this can be useful not only for classification, so for the identification of patients, COVID survivors who are really going to develop a long-term vascular consequence, but also for prediction, so predicting patients who will have a long-term increased risk of cardiovascular events, and most importantly, to have a reliable surrogate endpoint for clinical trials, because next sections will speak about a possible way to improve cardiovascular damage in COVID in COVID patients, we need reliable surrogate endpoint biomarkers to track these changes. So we will try to identify which is the best single test with the best predictive performance, but also to test machine learning approaches to have a combined index of vascular test with cardiac test and clinical data. Just a brief overlook of what it is the Cartesian project today. We have 52 participating centers all over the world in 25 countries in 5 continents. At this moment, we recruited more than 500 individuals, and our target is to reach 2,500 patients. This study has been funded by the Artery Society, but we also had the contribution of local funding in different nations and a support from VascageNet, which is a cost action aimed at exploring the value of assessing vascular aging for reducing cardiovascular burden. And indeed, this project has been born in this favorable environment. We started this VascageNet project with a small group of young investigators, and now we are more than 200 researchers from all over the world, especially from Europe. And if you are interested to participate or to adhere to the process, to the project, please have a look to our website, and you can directly send a form to join our cost action. So finally, I will show you some data about the impact of lockdown. So one of the most used social distancing measures to prevent COVID spread on vascular aging, so in non-COVID patients. It is clear that COVID-19 is a syndemic. It's not simply a pandemic. So it has huge effects also in people who are not infected by this disease. And this was, as Professor Luscher already explained, an increased rate of cardiovascular, a reduced rate of cardiovascular event has been paradoxically shown during the lockdown. So we decided to measure the impact of total lockdown, like this one we had in France, compared the control group in this natural experiment was Germany, a country which at that time, during the first lockdown, implemented only a partial lockdown. And we used a powerful tool to explore vascular aging, which is a smart bathroom scale, which is able indeed to measure reliably carotid femoral pulse velocity. And this user data can be also analyzed together with the data from other connected devices, such as smartwatches for measuring physical activity and smart blood pressure monitors. So here you can see our main results. You can see that during total lockdown, France experienced a marked reduction in vascular aging. So these people, indeed, they become 22 weeks younger in a period of 6 weeks, which was really a surprise for us. And you can see that this phenomenon is absolutely smaller in Germany, a country with a partial lockdown. What it is interesting is that this occurs despite no change in weight or fat mass, and despite a huge reduction in physical activity, as you can see here with the daily steps, and it was accompanied by a reduction in systolic blood pressure. And we tried to go a little bit further to understand if there are some cluster of trajectories in the French population. So during total lockdown, do the population behave in the same way, or there are some clusters. And indeed, we discovered that the vast majority of these French participants has no modification in vascular age, but we have two extreme groups which are very interesting. One extreme group who experienced a vascular aging of more than 3 years in just 6 weeks. And these individuals were characterized by male sex and by living alone. So it seems that these social characteristics may really impact the way we react to such an abrupt change in our lifestyle, such as a total lockdown. And on the other side, we have 20% of our French population who experienced indeed a reduction in vascular age of almost 3 years. And in this sense, it is interesting to realize that these individuals were exactly those ones who lost weight during lockdown. So individuals who took advantage of this particular moment of our life to implement some improvement in their lifestyle. So, with this preliminary data, I'm going to close my presentation, and I thank you for the attention.
Thank you, Rosa Maria. It was really interesting talk. There was one question coming from the previous talks, but also it is related with you, I think. Dr. Sedat Altuğ, who is the vice chair of our society, has asked the question. There are some healthy young people are dying due to cardiac complication. Is there any study or relation? He was saying that are they dying due to cardiac complication? And my question is adding on top of his question. Is there any study or relation showing these young people? What is the vascular age of these young people who are dying from cardiac problems during the COVID?
Thank you for this question. I think this is really the point, because we are stratifying a risk of complication for COVID based on chronological age, and this may not necessarily correspond to vascular age. This, of course, can be, it's only one of the main factors that may induce severe forms in COVID. We know very well that there are immunity aspects which are very important, and so on. But we really believe that this indeed knowing the vascular age of somebody can help us stratifying the risk of severe COVID too.
So it's a double effect. COVID causes vascular aging, and vascular aging can increase COVID consequences, I guess. Doctor?
This is a little bit the paradigm that is going to develop, as also Professor Touyz presents.
Dr. Matthias Barton is asking, and he's saying, thank you for very interesting talk. Did you measure markers of stress such as cortisol? And was this related to the aging or younging?
So not specifically in the study that I presented, but there are some really interesting study about the relationship of chronic stress burden and arterial damage. There are fantastic PET studies about this, who measured the stress, for example, with the FDG activity of the amygdala and arterial aging with the inflammation of the aorta. So with very strong and objective measurements of chronic stress, I would say. And it would be really interesting to study more into that. We are going to expand mostly the analysis about the EVA and supernova profile, just taking into account all these possible covariates.
And there is Yeşim Tunçok is telling, actually Professor Yeşim Tunçok can join and tell this question. Because she is the national coordinator of in Turkey for the Cartesian study, and she thanks actually to you.
No, it's indeed the Cartesian study was really the occasion to build new relationships between centers, and this is the occasion for me to meet Professor Tunçok, and so also the reason why probably I'm speaking here now. So it's really a pleasure to be in contact with this very active community in Turkey.
There is one small question. She thanks for your presentation, and she wonders if you have any finding on vascular demands related to vascular aging.
Oh, sorry.
The demands, vascular demands, demands and relation with the vascular aging.
And so not in this specific cohort, because we did not explore systematically cognitive function score in the Cartesian study, but there are many studies correlating cognitive function with arterial stiffness, because indeed large artery stiffness is associated with an increased pulsatility transmitted to the cerebral microcirculation too. So it's a constant source of microvascular damage in the brain. So this is really an important mechanism of vascular dementia indeed.
Thank you very much, Rosa. Because of we are a little bit late, I'm keeping the last question to the end. If we have time, I will ask, and I would like to thank you.
Thank you.
So I'll thank you, Rosa. So our next speaker is Professor Matthias Barton. He's a professor in cardiology at the University of Zurich, Switzerland. And he's originally from Germany and received his clinical training in internal medicine, cardiology, anesthesiology at Hanover Medical School and university hospitals in Basel, Bern, and Zurich. He has a particular interest in preventive cardiology, coronary artery disease, and atherosclerosis, as well as the molecular and vascular factors that determine health and disease. Professor Barton is part of the editorial board of the most important journals in the field of the cardiovascular science. He's a successful clinical scientist and has received several and various awards during his career. Professor Barton, please welcome and thank you for joining us today.
Thank you for the invitation, both to the Turkish Pharmacological Society and to ECCR, to speak to you today about COVID-19 and inhibitors of the renin-angiotensin-aldosterone system. I would like to talk to you about three things: some general considerations about SARS coronavirus 2 and COVID-19, then give you a very brief overview of where we stand. We've already heard from Dr. Touyz some of the data that has been published with regard to the effects of renin-angiotensin-aldosterone system inhibitors in COVID-19 patients. And then I have a slide with questions that I deem important and that I think can be answered or should be answered, maybe not today, but also to give some food for thought in the future and for future basic and clinical research. COVID-19 represents an anomaly with regard to different aspects. One of them actually being it's entering in the scientific literature. And as far as I know, this is the largest explosion of information related to a singular disease ever. This came from the necessity that because we didn't really know very much, we needed to gain knowledge very quickly. Data got published very rapidly, sometimes with peer review suffering. And there was another thing, actually two things that came into the game. One was the explosion of preprints, and the other was taking layperson and media taking part into the discussion of findings and actually discussing science in newspapers. And this was already picked up very early on in Science magazine. Until early May 2020, there had been more than 23,000 publications on SARS-2 or COVID-19. And in the first week of May 2020 alone, there were about 40,000 publications, 4,000 publications per week, which approximates to about 24 per hour or 3 per minute. And I think it's conceivable that no one of us will be able to keep up with that kind of accumulation of knowledge. Another thing that should be mentioned is that very often preprints were taken as science, though they were not yet peer-reviewed, and as fact. And this has, as we remember, resulted even in politicians and heads of states sharing their opinions about the suitability or effectiveness of certain drugs, which were later shown to be ineffective. What also happened, because there were problems with some of the papers that got published, and this is a paper actually reporting effects of renin-angiotensin-aldosterone system inhibitors, which obviously never existed, the so-called Surgisphere company data, which were retracted. But there's something that that happened afterwards that people did not appreciate, that these data actually didn't exist. And so these papers still get citations, and this month alone, which isn't finished, this particular paper got cited 38 times. And it's not just this paper. There's also another paper with data from the same authors, and it just so happens that out of the people who cited this work, more than half did not mention the status of having been retracted. And Ivan Oransky, who is an expert in publishing ethics, rightfully said, many authors just copy and paste lists of apparently relevant citation from similar papers without actually reading them. It's frightening, it's terrible, but common. And I cannot agree more with that. And I think it's all of our scrutiny, our own scrutiny, that we need to apply when it comes to citing previous publications, actually reading them. So where do we stand with regard to renin-angiotensin-aldosterone system inhibition and COVID-19? And we've already heard earlier from Rhian Touyz that there has been data published very early on. I'm going to mention that as well. This is a slide which we have seen before, was published in the New England Journal in a review in April last year. It's very, very much simplifying the actual situation, but what is important is that we can see here both main drugs, ACE inhibitors and ARBs, how they work on the conversion of angiotensin 1 to angiotensin 2, and that the main receptor responsible for all those consequences in tissue, be it the lung or the myocardium or the vasculature, is the AT1 receptor. And we can also see that there is the ACE2 binding to, or the SARS-2 virus binding to ACE2 at the cell membrane. And you can see on the left an actual picture of a electron micrograph with the spike protein, the S protein, being colored in pink. And I will go into this in a few minutes because the situation is not as simple. What happened then? In March, clinicians from Basel and Greece, they published a letter in Lancet Respiratory Medicine saying that they suggest that patients who are on ACE2 increasing drugs such as ACE inhibitors or ARBs are at a higher risk for severe COVID-19 infection, and they should be monitored, and there should be suitable alternatives for these patients, such as calcium channel blockers. This had immediate and extensive media coverage. It caused confusion and fear among patients taking ACE inhibitors and ARBs, and there are many of them, and patients actually stopped taking their medications. And to me, this is, I think this was the first time ever in medicine that I have experienced this, and I think it's a red flag to all of us that we should not, if we have a hypothesis, that we should be very careful in how to phrase it and what to do with our hypotheses. Consequently, the societies, the cardiovascular societies, American ones, European ones, and also national ones, they issued letters of information where they told the patients that there's no need to discontinue their treatments. This was published about 6 weeks after that, but it's a piece by Mari Essler and Danielle Essler, who are basically saying the same thing, that prescribing ARBs might actually be harmful, and that other antihypertensives should be preferred. And at the time, John Paolo Rossi and Viola Sanga and myself, we took this opportunity and very quickly put together this short report where we warned about discontinuing these drugs, and also summarized the evidence for the protective effects of these drugs, not only in the cardiovascular system and for the kidney, but interestingly also for situations such as acute respiratory syndrome, which has been well documented. And what we included, and this is the more comprehensive cartoon in this report, was a description of, you can see ACE inhibitors and ARBs on the left here, the description of the different components and players in the system. And as you can see, and I've already mentioned, AT1 receptor does all the things that will eventually lead to ARDS. But on the other hand, you have a peptide, which is angiotensin 1-7, which is sort of the player playing against the system, which provides organ protection. And you can see here, and I ask you, I'm not going to go in too much detail. You can read the article, and it activates 3 different receptors: the AT2 receptor, the MAS receptor, and the MAS receptor G protein coupler receptor D. And we don't really know very much how this contributes to any of the effects that we do see with ACE inhibitors or ARBs, but there will be some. And this was the first study in this regard. We already heard from Rhian Touyz today. This was the study that was done in China, so there may be some limitations with regard to whether or not this may also work in other ethnicities, that kind of degree of protection. This is a study in hypertensive patients, and it's a retrospective analysis. And as you can see, treatment over 28-day follow-up markedly reduced mortality almost by 2/3. And this is really a remarkable study. This was the first study, and it was quickly followed by 2 other studies published back-to-back in the New England Journal on May 1. These investigators, one group was from the US, the other one was from Italy. They found, also looked at other antihypertensive drugs, and they found no substantial increase in the likelihood for COVID, for a positive test for COVID, or for a risk of severe COVID with being treated with any of these drugs. And the same was also confirmed in a different population in Italy. So these data told us that there was apparently no harmful effect. And just 2 weeks ago, a paper came out from France, which looked at a cohort of 2 million hypertensive patients. And they looked at whether or not treatment with either an ACE inhibitor, an ARB, or a calcium channel blocker as antihypertensive treatment did affect the hospitalization risk for COVID. And what was interesting was that both ACE inhibitors, even more so, and also ARBs, were associated with a lower risk of COVID hospitalization compared to calcium channel blockers. And the same was the case for the risk of intubation or dying from COVID. And I think these are really interesting data because they somehow tell us that these were patients that didn't know whether or not they were going to get COVID. And they tell us that there must be something with these drugs going on that we don't quite understand, that may affect immunity or the response to the virus. And this just happens to have been shown, was published last week in hypertension, also published in hypertension. And this is a group which has previously shown that angiotensin 1 mediates ACE2 enzyme internalization through endocytosis via clathrin-coated pits, followed by lysosomal degradation. And they postulated that maybe the spike protein, which you can see in pink on the electron micrograph on the left, that this may also be sensitive to AT1 stimulation. This is actually what we can see on this cartoon. On the upper, these are cells that do not express the AT1 receptor. In the A panel, you can see the effects once you transfected the cells with the AT1 receptor. And you can see it also in panel D that once you do that, your ACE2 will disappear. It will be reduced. It will be internalized, and this effect is blocked by losartan, which is a AT1 receptor antagonist. And this, to me, puts a new, really a new picture to the understanding of why AT1 antagonists might be efficacious in preventing worsening of clinical course in patients diagnosed with COVID-19. And just the last study I would like to mention, this will be published in Journal of Experimental Medicine in March, has been published online. These investigators, they looked at the role of SARS-2 neuroinvasion. We know that the brain is also a target for hypertension, for macrovascular disease, for stroke, or for microvascular disease and dementia. Very interesting, what they found was that there are ischemic infarcts in the brain, that the blood-brain barrier breaks down. There's neuroinvasion of the virus, and they also used some animal models, and they could show that neuronal infection could be prevented by blocking ACE2 with antibodies or by administering cerebrospinal fluid from a COVID-19 patient. And being a target for and we're looking at endothelial cells and small arteries and arterioles here. So this is a vascular territory, and certainly because it's a vascular territory, also target for renin-angiotensin-aldosterone system inhibitors. I think this is something we need to look at also, not only at the cardiovascular system, heart failure, etc., but also at brain injury and possibly consequences such as dementia. So the questions that I've put together as some final questions, there are three groups, if you will. The first one I've already touched upon is whether renin-angiotensin-aldosterone system inhibitors effects, can they be really solely explained by target organ effects? I think this is a very general and important question. And the next 5 questions are all clinically related. So who are the patients who benefit most from renin-angiotensin-aldosterone system inhibitors? Are there patients, COVID patients, who do not benefit, and why? We've heard about aging before. One question would be, does aging affect renin-angiotensin-aldosterone system inhibitor efficacy in COVID-19 patients? And if so, why? Then a question that I find particularly interesting is, are the inhibitor effects, are they equal in men and women? We know already from the literature that there is there's sex difference with regard to this class of drugs. And one question I think that we will all have to deal with is, will COVID-19 organ damage impact long-term global health? And finally, one question that's not clinically related, but maybe because we are using drugs to target the system, we're always talking about the renin-angiotensin system, but it's actually the renin-angiotensin-aldosterone system. So my question would be, is there a role for aldosterone or even mineralocorticoid antagonists in COVID-19 patients? And we know that many of these patients are diagnosed with diseases such as heart failure and are on those drugs. And that's also a question that I'm interested in. And with that, I'll be happy to take any questions.
Okay, thank you, Professor Barton, for a very nice presentation. We have time for some questions here. So there is one question that actually came up in the chat and several, for more than 3 times, which is, are there an ACE2 modulating medications?
Are there ACE2 well, you will see changes even with ARBs or with ACE inhibitors. So that was the initial, the Lancet letter that I mentioned, that was based on that assumption that increasing circulating levels of ACE2, which we'll see with these drugs, might increase the risk of an infection, and thereby providing it's also on the tissue, providing new entrances for the virus, and this way worsening the disease. The thing is that there are approaches now to use recombinant ACE2 actually to scavenge the virus. And there are some drugs that have been developed which are modified ACE2 proteins, which are not identical with the human ACE2, but they will still scavenge and bind to the virus and thereby eliminate it.
Okay, another question here. Do you think that switching ACE inhibitors to other drugs such as angiotensin receptors and prednisone inhibitors could be a better choice in patients with heart failure to prevent deleterious effects in COVID-19 infection?
Well, we know about the recent trials in heart failure about these drugs, which are also given in combination. My answer to that question would be it will depend on two things. It will depend on whether or not you will reduce the amount of angiotensin generated. And with regard to this pathway, this comes even before ACE2 and ACE1, and actually before angiotensin 2 is formed. So I cannot answer that question. And I would also think, because heart failure patients are on multiple drugs, it would also depend on the drugs they're already on. And you would not want to attenuate any of the wanted effects that you are having in these patients already on therapy.
Okay, so one last question is that there is this study that was presented here that ACE inhibitors and statins prevent death. However, ARBs do not prevent COVID-19 related death. How can you explain these findings?
I'm not sure if I understood correctly. So the paper that Dr. Touyz and that also presented, I think there was a reduction in death, and that was quite significant. I don't think we can close the book right now as to whether or not any of these drugs have advantages or disadvantages. But what we can say is that the effects that we see in mortality, they are not related necessarily to COVID. And that's actually also a question that Dr. Touyz touched upon. So we're seeing the highest mortality we're seeing in the elderly. These are patients with numerous comorbidities. Many of them have hypertension. Many of them have a heart condition. And if you remove those drugs that are actually protective on the systems in the context of an infection, this is where I think where the question should go: should we discontinue them or not? And I can just repeat what we published about a year ago, that we shouldn't.
Okay, so thank you very much, Professor Barton. So now we go for a very nice presentation. Now we go for the next session.
Thank you, Dr. Barton. And now our last talk of this round will be presented by Dr. Gökçe Topal, who is actually the person who is organizing, who is the important person for organization of this webinar. Let me introduce you Dr. Gökçe Topal. She is graduated from Istanbul University Faculty of Pharmacy, and she is currently working at Istanbul, at the same place at the Istanbul University Faculty of Pharmacy, Department of Pharmacology. She has obtained her PhD degree in pharmacology from Paris, Rhian Touyz University. Her research is focused on vascular pharmacology, inflammation, and bioactive lipids. And she has over 15 years of experience in vascular pharmacology and bioactive lipids, published extensively in peer-reviewed international publications, abstract and conference proceedings. And her research was funded by national and international research councils. She is member, we are proud that she is member of the executive committee of the Turkish Pharmacological Society and a member of also European Society of Lipid Mediators. Now I would like to invite Dr. Gökçe Topal for her talk on vascular endothelium and inflammation, bioactive lipid mediators, a target for therapeutic intervention or not.
Thank you very much, Günay, and good afternoon, everyone. Firstly, it's a great honor for me to be part of this important webinar with a very distinguished speakers. I'm also very happy to be here virtually with you today, but I hope that we will meet again in face-to-face meetings very soon. And today, this presentation will deal with the potential effects of bioactive lipid mediators in the treatment of COVID-19, but mostly we will focus on vascular endothelium and inflammation. And to begin with, we will be very quickly talking at the effect of COVID-19 on endothelium, because this issue, this point has been extensively discussed in previous presentations, which were really very interesting and elegant. Then we will continue with the bioactive lipids, but we will focus on icosanoids and omega-3 fatty acids pathways. And also we will take a look at some results, some examples of results from our lab. And finally, we will discuss the main objective of this presentation, which is to make a picture on recent articles that are published on COVID-19 and bioactive lipids. But unfortunately, these papers, most of them will be hypothetical and opinion papers. We will discuss at the end. And as we have discussed previously, now the emerging evidences indicates that endothelial cell dysfunction is a central feature in COVID-19. And this is evidenced by the critical role of vascular endothelium in inflammation, which is also very important matter in the cytokine dysregulation in COVID-19, especially in severe COVID-19. And endothelial cells can be, and endothelial cells widely expresses ACE2 receptor. Therefore, the endothelial cells can be directly infected by coronavirus. And this infection can cause the endothelial inflammation, in other words, endotheliitis. And endotheliitis might be attributed to the increased production of pro-inflammatory mediators like pro-inflammatory cytokines or pro-inflammatory chemokines that are released from dysfunctional and injured endothelium. But at the same time, the endothelial cells can be exposed directly to the pro-inflammatory cytokines and systemic inflammatory response referred as cytokine storm. So the vascular endothelium might provide a new therapeutic interventions, especially for protecting and stabilizing the endothelial functions. The agents that can limit the endothelial dysfunction can reduce the activated prothrombotic and the pro-inflammatory state of endothelium. Therefore, the controlling local or systemic inflammation is now considered as very important as antiviral therapies. And in the clinical settings, there are some anti-inflammatory medications that are used in the treatment of COVID-19. And also there are some medications very well known like statins that can be suggested to use for just preserving, for just protecting the endothelial functions. But also in day by day, and there are some recent papers that are published and suggest the potential beneficial effects of bioactive lipids for just combating the consequences of the coronavirus. And these authors mostly suggest that icosanoids and omega-3 fatty acid pathway, but especially the resolution of inflammation and also the pro-resolving lipid mediators. And for just to make a short reminder that icosanoids are synthesized from arachidonic acid, and arachidonic acid catabolized by 3 different enzymatic pathways. And the first one is the COX conversion to prostanoids, and cytochrome P4050 conversion to epoxy isotretinoic acid, EETs, and lipoxygenase conversion to leukotrienes. But in this presentation, we will talk a lot and we will discuss especially the PGE2 and prostaglandin E2, and also an enzyme, MPGS1, that is responsible for the synthesis of PGE2. Also, we will discuss a lot about the role of the effect of EETs, because EET is a very new group of bioactive lipid mediators, and it is now documented that EETs can exert endothelial and vascular protective effects. And also EET is rapidly metabolized by soluble epoxy hydrolyase inhibitors. So the authors suggest to use the inhibitors of soluble epoxy hydrolyase to increase the EET levels. And the second, and afterwards, we will discuss the omega polyunsaturated fatty acids. As we have very well known, the EPA and DHA, the omega-3 fatty acids, many studies, and especially many experimental studies and some clinical trials have demonstrated the cardiovascular beneficial effects of EPA and DHA. And there is also another new group of bioactive lipid mediators called specialized pro-resolving lipid mediators, SPMs, like lipoxins and resolvins and marasins and protectins. And these specialized pro-resolving lipid mediators affects different type of cells like monocytes, macrophages, endothelial cells, and T cells. And also recent studies demonstrated that the cardiovascular beneficial effects of omega-3 fatty acid might be attributed to the synthesis of specialized pro-resolving lipid mediators. Firstly, SPMs mediate and orchestrate the endogenous resolution of inflammation, which is a series of cellular and molecular events that can lead to the progressive regression of the inflammation. And SPMs especially induce the pro-inflammatory cytokines and NF-kappa B activation, but mostly they induce the clearance of the cellular debris, and also they reduce the anti-inflammatory cytokine production and release. So before just going on the last part for the discussion of the papers, I just want to show some results of our studies from our lab. And also I just want to thank all the lab members, Zeynep Çelik, Gülsev Özen, Armontacı. And also I just want to thank two main collaborators of our lab, Mick Dashwood, from University College Medical School. I think now he's watching us. And also Xavier Norel from Eastern Paris North University. And the first paper I just want to discuss with you was related to that. In this paper, we suggested that inhibition of microsomal PGA synthase 1 enzyme can reduce the human vascular tone by increasing prostacyclin. And this might be a safer alternative to COX-2 inhibition. In this paper, we selectively inhibit the MPGS1 enzyme, and therefore there's a reduction in PGE2 release, and also, but in contrast, there's an increase of the prostacyclin release. Therefore, in this study, we suggested that inhibition of MPGS1 enzyme by a selective inhibitor, for example, compound 3, might reduce the human vascular inflammation and human vascular tone. And now the other papers that we focus are the papers that investigate the potential beneficial effects of omega-3 fatty acids. And in this paper, we demonstrated and we suggested that EPA and DHA supplementation might reduce the human vascular tone and human vascular inflammation. And these papers suggest that and demonstrated that omega-3 fatty acid supplementation might exert some potential endothelial protective effects. But in the last part, we will discuss the recent literature related with the COVID-19 and bioactive lipids. And the first paper that I just want to discuss with you was published on Cancer and Metastasis Review on this May 2020 with a group of Deepak Panigrafi and Charles Serhan from Harvard University and Bruce Hammack, very important names, scientists in the field of resolution of inflammation and bioactive lipids. And in this study, the authors suggest that the resolution of inflammation might be a new therapeutic approach for combating the cytokine storm in COVID-19. And these figures represent the alveolus. And the left one, the authors suggested that viral-induced alveolar cell death can cause the accumulation of apoptotic and necrotic cellular debris. And these cellular debris can induce the release of icosanoids in large quantities from macrophages, which can generate the icosanoid storm, and icosanoid storm can cause the robust increase of pro-inflammatory cytokines that can generate the cytokine storm that we have observed in severe COVID-19. In the right part, the authors suggested that the supplementation of soluble epoxy hydrolyase inhibitors for just increasing EET levels and the treatment of SPM first might induce the clearance of cellular debris, which can also inhibit the release of pro-inflammatory cytokines and also inhibit the leukocytosis and also activates the adaptive immune responses. So the authors suggest that SPMs and soluble epoxy hydrolyase inhibitors are now currently in clinical trials for other inflammatory diseases could be rapidly translated for the management of COVID-19 through debris clearance and inflammatory cytokine suppression. Another paper, there's another hypothetic paper, which is also supported the previous one. In this paper, the authors suggested that viral infection can cause the accumulation of apoptotic and necrotic cell referred as cellular debris, and this cellular debris can cause the icosanoid storm and cytokine storm. But when there's a treatment of SPM, specialized for resolving lipid mediators, this can initiate the resolution of inflammation, which can cause the infection and clot resolution. Also, another mini review paper that was published on the American Journal of Pathology on this September 2020 with a group of Bruce Hammock and Deepak Panigrafi again. And the authors suggested that when there is a coronavirus infection, this can cause viral-induced cellular debris, which can induce the endoplasmic reticulum stress, which can cause inflammatory enzyme induction like MPGS1 or COX-2, which can initiate the generation of icosanoid storm and cytokine storm that can cause widespread inflammatory responses. And the authors also suggested that inhibiting soluble epoxy hydrolyzes can augment the EET levels. This augmentation can diminish the endoplasmic reticulum stress and also can inhibit the inflammatory enzyme induction. And the author proposed that soluble epoxy hydrolyase inhibitors alone or in a combination with other agents such as COX inhibitors or omega-3 lipids can be beneficial for just blocking or moderating the inflammatory cascade in COVID-19 patients. Maybe we can add that maybe in combination with MPGS1 inhibitors, it can be beneficial for just reducing the inflammatory responses. And now we can continue with the prostaglandins, another review paper, which was published on British Journal of Pharmacology on this July. And this paper, the authors discussed the literature about the non-steroidal anti-inflammatory drugs, prostaglandins, and COVID-19. But in this presentation, we are not focusing on non-steroidal anti-inflammatory drugs, but the authors also in this review discussed the possible mechanisms for PGE2 modulation of immune cell function in COVID-19. It's a very complicated figure, but I just want to summarize it. Firstly, in alveolar epithelial cell, there's expression of TMPRSS2 and ACE2. And after binding of coronavirus to these ones, they can induce endocytosis and viral replication. And the viral replication can cause the activation of NF-kappa B, which can cause the robust increase of cytokines and chemokines. Also, NF-kappa B activation can induce the expression of COX-2 and MPGS1. And MPGS1 can initiate the increased release of PGE2. And PGE2 has a diverse function, can control diverse function. But in monocyte and macrophages, PGE2 can inhibit viral clearance, but at the same time can activate the release of cytokines and chemokines that can also induce the recruitment of monocyte and neutrophils that can also generate the cytokine storm. So in this review article, the authors suggest that inhibiting MPGS1 can be a good approach, a new therapeutic approach for just combating with the hyperinflammatory responses, especially observed in severe COVID-19 patients. Another hypothetic paper, which is a preprint now, but it also supported the previous suggestion. And also in this hypothetic paper, the authors suggest that the PGE blood levels might be measured, and also the inhibiting of human PGS1 can be a good therapeutic approach. And they suggested that a drug currently in phase 2b studies for mitochondrial disease called as sonelokimab can be a good candidate and might need to be investigated in the pathophysiology of COVID-19. Well, now we can continue with the omega-3 fatty acid pathway. And there are also some data about the omega-3 fatty acid supplementation and the treatment of COVID-19, and there are some papers. But if we summarize these studies, we can tell that omega-3 fatty acid might have potential benefits, but at the same time might have some potential adverse effects. Firstly, EPA and DHA can increase the less inflammatory icosanoids while decreasing pro-inflammatory cytokines, but especially EPA and DHA supplementation can increase the specialized pro-resolving lipid mediators, which can mediate and orchestrate the resolution of inflammation, which can decrease the systemic inflammatory response. At the same time, an EPA and DHA supplementation might exert antiplatelet effect and also can have some potential antiviral effects. But in contrast, and on the other hand, omega-3 fatty acids are very sensitive to non-enzymatic oxidation by reactive oxygen species. Therefore, that can be a potentially toxic oxidation products of omega-3 fatty acids. Therefore, that can be an increase in oxidative stress. And also the omega-3 fatty acid supplementation might might cause a delayed virus clearance. Therefore, now there are two clinical, very important two clinical trials are on their way in COVID patients, especially with the elderly patient, which aims to evaluate whether omega-3 fatty acid diet enrichment could protect patients against severe forms of COVID-19. But although the inflammatory resolution improved by EPA DHA could exert some beneficial effects, but we need more randomized and controlled trials for the recommendation of omega-3 fatty acid supplementation. And for the final conclusion, also, I just want to discuss with you another article and review article that we have prepared. And this article, we have discussed, we made an overview regarding the possible effect of COVID-19 on the patency rate of coronary artery bypass grafts, such as human saphenous vein and human internal mammary. And in this article, we discussed the therapeutic potential of focusing on endothelial dysfunction, especially vascular inflammation and thrombosis. And also we discussed that maybe icosanoids and omega-3 fatty acid pathways might be a new therapeutic target, especially for the progression and stabilizing the endothelial functions. And for to conclude, and we have reviewed recent articles, recent hypothetical and opinion papers, and these papers suggest that targeting bioactive lipids might diminish the systemic hyperinflammatory response, might reduce the cytokine storm, especially by inducing resolution of inflammation and also by inhibiting MPGS1 and soluble epoxy hydrolase enzyme. But overall, the vascular endothelium now promotes a new therapeutic target for interventions, but it remains to be determined whether endothelial dysfunction can be caused by direct injury of coronavirus, or it can be caused by indirect injury of cytokine storm. But never mind, it has been now suggested that targeting endothelium may provide better outcomes in COVID patients. And the previous studies, including ours, demonstrated that icosanoids and also some mediators in omega-3 fatty acids pathways can exert cardiovascular beneficial effects, especially by a regulation of vascular tone or by reducing of endothelial and vascular inflammation, and also inhibiting of platelet aggregation. Therefore, it might be reasonable to suggest the use of MPGS1 inhibitors and soluble epoxy hydrolase inhibitors and treatment of pro-resolving lipid mediators or supplementation of omega-3 fatty acid pathway might decrease the endothelitis and can have a good impact on endothelial functions. But especially we need to publish data rapidly in this field because we need experimental results and experimental data result. But maybe SPMs and soluble epoxy hydrolase and MPGS1 inhibitors are currently in clinical trials for other diseases, might be rapidly translated for the management of COVID-19. And the targeting bioactive lipids might be a novel therapeutic approach in combating consequences of coronavirus. And at the end, I just want to thank these two societies, ECCR and Turkish Pharmacological Society. Also, I want to thank all of you for your attention. Thank you very much.
Thank you very much, Gökçe, for very interesting talk. I have several questions, but also you can send your questions here. My question is, it's very interesting, the soluble epoxide hydrolase inhibitors potential effect on COVID cytokine storm. What kind of natural molecules, or do you know any drugs? It can be in the drug repurposing aspect you can approach. Is there any drug that can inhibit also soluble epoxide hydrolase?
Yeah, of course, there are some, for example, candidate, not drug, but the drug candidate that are in the phase 2B studies, especially because for example, mostly for the neurogenic diseases, for example, from multiple sclerosis or for example, some also inflammatory disease, there are some drug candidates which are in phase 2B studies, but now up to now, we don't have any approved drug now related with the soluble epoxy hydrolyzers.
Zeliha Yazıcı is asking if could PGA prostaglandin S1 inhibitor be superior to corticosteroids in terms of cytokine storm and prostaglandin synthesis and other things?
I think in briefly, we cannot compare with the MPGS1 inhibitors with the corticosteroids. It's different now. We don't have any data for the comparison, but we can tell something. Corticosteroids have some side effects, very important side effects. MPGS1 inhibitors now also are in the clinical trial, but we have very early results of these clinical trials, but we can tell that from our studies also MPGS1 has some beneficial cardioprotective effect. This can be a 1+ for the glucocorticosteroid, but we are not sure about it. We cannot compare now these two, one drug candidate with a very known corticosteroids.
And actually, this may be, okay, I have a question, and behind this, to understand the reason, we can think about loss of reason. But in Norway, in Denmark, we know that the omega-3 usage is higher than the other countries, and this was one of the reasons that their cardioprotective effects started to be shown. What is the mortality rate? I know the mask usage, there are different subjects, but do you have do you know any study showing their mortality rate and also dependent on the omega-3 usage?
Yeah, it's still under debate because there are no very solid data about this, because there are some clinical trials that investigate the beneficial effects of omega-3 fatty acids, but there's a discussion about them because it's very difficult to make a clinical trial for stabilization of patient, because there are some omega index status of the patients, but up to now we don't have very solid data about the cardiovascular beneficial effects of omega-3 fatty acids in clinical trials.
Okay, thank you very much again for all our speakers and Dr. Gökçe Topal. Now I would like to invite Professor Maria Soledad Fernandez-Alfonso from European Council of Cardiology Research for the closing speech.
Thank you, Günay. We come to an end, and I have to say that I'm really happy because I think that this has been an excellent webinar with really outstanding talks, exciting data and great science, and also with a very active discussion on the chat. I would like to stress, because I think since this is not only a scientific activity, but also a formative activity, I would like to stress the concern raised by Matthias Barton about the ethics in research and publishing we have experienced related to COVID-19. I think that this is a crucial issue, and that as scientific societies, we need to encourage our researchers and students to be very critical and careful, of course, with their own work, but also with the PubMed reviews and the citations, because I think that in these days, ethics and integrity in research must be preserved. Okay, so said this, I would like to thank the speakers. Your participation was really a privilege. The moderators, Günay and Francisco, you did a great job. The Turkish Society of Pharmacology, with special thanks to Gökçe Topal, who was the link between both societies, and she worked really hard on different organization details. And also, I would like to great thanks to Ahmet Altun, who was responsible for the organization of the technical aspects, the design of the YouTube streaming. It worked perfectly well, Ahmet, and I want to thank you especially. As Gökçe said, already pointed out, I hope that we might continue the activities between both societies, and that we might meet face-to-face soon. And last, I would like to thank President of the Turkish Society of Pharmacology, Professor Yeşim Tunçok, for the nice collaboration, and I give the floor to you to close the webinar. Thank you very much.
I would like to thank you, Marisol, and the other colleagues and all our speakers, and also our participants with their contribution, valuable contribution. We finished an excellent scientific webinar with your contributions, and also with your collaboration, the ECCR collaboration. We hope that we would like to meet you in the face-to-face meetings, maybe in the upcoming our upcoming national congress. Gökçe and Günay are the congress secretaries, and we will be in contact with you with in collaboration with some sessions in our national congress also. And we will have also social webinars in the next months, but maybe in Turkish, I don't know. In English we can do it. Please follow us and follow the Turkish Pharmacological Society's activities, all activities, both scientific and social activities. Thank you for everything, for everybody, for valuable contributions. And I would like to say goodbye to you. Have a good evening, and have a good year, new year to all of you. Bye.